I'm Julie, one of the FY1s working at St James's on respiratory. Haven't actually got a GI job this year, but I've been given this one to teach you. But it's only kind of just focusing on the OSCI. So I think, have you had your GI lecture for HPB last week or something, haven't you? So I'm not going through how to do a GI exam and stuff, because I think everyone already knows that. So I'm just going over what's come up in the past and specific things that have come up and what you'd look for there, and differential diagnoses, histories that have come up in the past, specific questions for those. So it's more kind of a focus thing rather than just normal how to take a full history, how to do a full examination. So I'm going to start off, so that's what I'm going to be doing. So just common things that have come up in the past, going over some differential diagnoses, going over some investigations that you'd be expected to tell the examiner you'd be doing, some appropriate management things, talking a bit about paperwork, and just some kind of hints, tips from OSCI last year and things. So we're going to start with history first, and we're going to start with my topic of diarrhea next. So first of all, in the history, I think everyone knows already, it's a mixture of 12 minutes and 8-minute stations. We had all the 12 minutes in one day and all the 8 minutes in one day, which was quite good because you knew that all the examinations were going to be on a separate day, and it was just explanation one day. I assume it'll be the same this year. In the 12-minute stations, it's all explanation stuff. The examiners don't really tell you to move on, so you've got to be quite careful with your time, because there's normally taking a history, possibly coming with a diagnosis, explaining something to one of the patients, filling out some paperwork. So just be careful of your time with that, because they don't usually tell you if you're running out. And I'll just be going over like presenting in categories and everything. So with differential diagnoses, always do it so cardio, respiratory, infectious, always do it in categories. And the same with investigations, start with simple bedside things, bloods, before you go on to the big imaging things. And so they're just like categories. When I did my OSCI, everyone always asks whether you should talk when you go through it or you shouldn't talk when you go through it. I just talked. I think most people did. I didn't do it as much as third year, but you just need to be explaining to the patient what you're doing. I think it's a bit weird when someone's just totally silent. I don't know, because you wouldn't be like that in real life. You'd be telling the patient what to do. So we've always been told it doesn't matter, just do what you want to do. But I feel better talking through it a bit, just as if I'm talking to the patient more than the examiner, but just telling them what I'm doing and why I'm looking at things. Okay, so first of all, I'm going to talk a bit about causes of diarrhea, then we're going to look at a case scenario. So first of all, again, if you split it up into sections, so you've got anatomical causes. Originally I tried to set up this presentation so it came in chunks, but it hasn't done it, so you just got all the information there straight away. So first of all, you can look at chronic causes. So obviously inflammatory bowel disease is a massive one. Ischemic colitis, diverticular disease, really, really common in the older generation of people. And obviously things like malignancy, looking for red flag signs and stuff. Small bowel, so Crohn's disease, celiac, all quite common things. Lymphoma, less common. And radiation, say if they've got a history of cancer and they've had radiotherapy. Also things like pancreatic insufficiency, people with CF, again malignancy. Then you look at things like functional, so IBS, really, really common. And also, don't forget things like endocrine, so hypothyroidism. So if you have someone with diarrhea, always remember to ask about all the systems. Also, obviously, drug side effects, laxative use, things like that. Just remember to ask questions about everything. To get back to here, has been in hospital with an appendicectomy. What do you think they've had that could have caused this in hospital? Yeah, so this is like a classic thing that could come up. So medication use, so antibiotics. So also look at food contact, what they do, have they been travelling recently. Also look if there's a past medical history of anything, like inflammatory bowel disease, if they had any surgery, if they've ever had cancer before, and again cover the thyroid, and also look at family history for things like inflammatory bowel disease as well. So you're thinking C. diff with something like that. So just a little bit about C. diff. Antibiotic induced, usually between 4 to 9 days, but it can be up to 8 weeks later. This is more kind of MCQ, so if you don't really need to know this for an OSCE, but just to let you know, it produces 2 exotoxins, and it increases the vascular permeability and pseudomembrane formation. So if you look at risk factors, obviously being in hospital, you have a weakened immune system, previous C. diff, taking broad spectrum antibiotics or multiple antibiotics and long-term antibiotics. So what you'd have to do in an OSCE is obviously explain what C. difficile is, like in the scenario before, and it'd explain what you'd be doing. So they would be doing a stool immunoassay for the toxins, and they may require sigmoidoscopy or colonoscopy depending on their other symptoms and things. I think you're also required to know the treatment of C. diff for your OSCE or for your written, which is oral metronidazole, vancomycin, obviously stop the antibiotics that have been causing it, and general hygiene when they go to the toilet, and IV fluids because they're going to be really dehydrated with all the diarrhea. Complications is also quite a good one. Could come up in a slide. I've got some slides at the end. So perforation, an ileus, peritonitis, and a toxic megacolon. So with pericarditis, it just could come up in an MCQ. You'd see saddle-shaped ST elevation in all leads. It's quite a classic one to possibly come up. So if someone was suffering, if someone came in, what kind of key questions would you ask with regards to either dysphagia or dyspepsia? If someone came in with a problem, what do you want to know? What are the most important key things that you want to know? Yeah. And do you know which would come first? Yeah. Anything else? So just the same as always. Solids and liquids first. What came first? Is it painful? Duration, location. Can they tell you exactly where it is? Does it come and go, or is it gradually getting worse? And really importantly, any associated symptoms that red flag things that'll point you towards kind of a diagnosis. So again, with dyspepsia, exacerbating relieving factors. And you also want to know, you want to rule out bleeding and things. You want to know if there's any melena. So you always, in anything GI, ask about like top and the bottom. So always ask about bowels. Remember on the drug history about iron supplements, because people can get confused about melena because that actually can look like melena. Always ask about vomiting. And also think about either in hospital, are they on any VTE prophylaxis with regards to bleeding. Okay. So, and always the red flag symptoms and family history of things. Okay, so just to look at another case. So, you're an FI1 working in A&E. A 60-year-old man has been sent in by his GP with a haemoglobin of 8.1. So, please take a focus history, provide possible differentials, and explain any investigations you will be ordering. So, if you got that, what would be the main questions you'd be thinking about asking this man? Yeah. Anything else? Yeah. So just all the usual, you want to, all the red flag things, all the usual questions that you all know to ask anyway. So this is what he tells you. So he's 60, he's been getting very bad heartburn recently, especially after meals and at night. He's tender at the top of his tummy, he's got no swallowing problems, he's had about 1 stone weight loss in the last 6 months, decreased appetite. He's a smoker, he's got high alcohol intake, he regularly takes NSAIDs, he has melena several times recently, but you've got to specifically ask about this in people, so always remember melena, it's a really important one. He tells you he's due to attend a breath test at his GP's, but he didn't go. He's got a past medical history, ischemic heart disease, and he's on aspirin, ibuprofen, and omeprazole. So what are you thinking of possible differentials with that? There's a couple of things. What are you thinking? Yeah? Anything else? Yeah. There's no swallowing problems, but still, yes, weight loss and things, you've got to think about that. Possibly gastric cancer as well, but yeah, they're the main things definitely that come across from the history. So yeah, that's right, so it's a peptic ulcer. So just a little bit about peptic ulcers. So duodenal ulcers are 2/3 more common than gastric, where you would get burning prior to meals and at night. So 50% are asymptomatic, other half don't really know they've got it. And there's a very strong association with H. pylori, NSAIDs and smoking, so he's got all of those. So what you need to do is rule out if you've got H. pylori, so urea's breath test. And with the weight loss and the bleeding, you'd definitely be doing an OGD. So some complications of peptic ulcers. So obviously perforation, GI bleed. Gastric ulcers are also associated with malignancy, so you've got to remember that. And treatment, so proton pump inhibitors and obviously H. pylori eradication is the most important thing. Okay, so we're going to look a bit at upper GI bleed. This is going to be covered, I think, in more detail in like the acute emergency lecture. I don't know if you've had surgical emergency one, I don't know if you've had that. So we're just going to look at a few causes of GI bleed. So if you look at variceal first, so you can have esophageal or gastric, and then there's non-variceal. So again, you've got peptic ulcer disease, which is the most common, esophagitis, and you sometimes see Mallory-Weiss tears in A&E. Do you know Mallory-Weiss tears, what they're caused by? Yeah, so you sometimes see them in A&E, but they're not as common. So other more rare things, aortoenteric fistulas. Malignancy is one thing you've got to be careful about and rule out. Again, you'll be doing that with all your red flag signs and everything, and your OGD and everything. People with coagulopathy disorders, so with anyone with bleeding, we'll look into this in a minute, but the bloods are really important, that you look for clotting and anything like that. Sometimes people come in with really severe epistaxis and they're thinking that it's, coming up the other way, so just be careful to rule out that as well. And then, again, rare arteriovenous malformations, but we've got someone on the ward with that again, so you do see it. So, key things, I was going to ask you the key things to ask, but it's already there. So, again, you want to know as much information as you can. So you want to know the colour, is it the bright red, or is it coffee ground, really dark? Is it mixed in or throughout vomit, or if it's low GI, is it mixed in or throughout the stool, again, bright red or dark? How often is it happening, and how much? Get them to try and in mils, see how much it is. You want to be looking at the stool colour again, like I just said. You want to be looking at any change in bowel habit. Also, you need to also ask about anything. You don't want to just be focusing on one system, because you need to show that you're thinking about all of the systems and all of the possible causes. So always asking like things about chest pain, any abdominal pain, any dysphagia like we talked about earlier. There's a huge list which you all know to ask for. You just need to cover everything. So past medical history, especially any coagulopathy problems, especially liver problems, drinking, medication is a big one. So normally you see the alcoholic people with the varices, and the people on the NSAIDs smoke, and that's what you usually see. Okay, so just going to go over a bit of management of an acute GI bleed. So obviously everyone knows you do everything A, B, C, D, E. I'm sure everyone knows how to do that. I printed off these guidelines here for GI bleed, if anyone has any more questions on it. So you do A, B, C, D, E. The most important bloods that you want to be getting are obviously your full blood count, definitely clotting, Usinase, LFTs, glucose, amylase, which isn't there. For quite a low risk person, you could just be doing group and save, but for a really intermediate to high risk person, you'd be wanting to cross match 4 to 6 units. And always do an ABG if they're drowsy and well. always do an ECG, just in anything, ABCD, always do an ECG, and I haven't got this here, but an erect chest x-ray just to rule out any kind of perforation or anything like that. So an OGD is the thing that allows diagnosis and definitive treatment. But you'd only do this after they're adequately resuscitated. This is your job to adequately resuscitate them. So before doing anything else, you're going to be expected to obviously do the ABCDE, get the cannulas in, get them resuscitated, and that's our job to do that. And then we'd go on to the definitive management. So it's really important, obviously, anyone with a GI bleed, they need to be nil by mouth until the OGD, and covered in your ABCDE, obviously they need to be on oxygen, they need to have the 2 large bore cannulae in, they need to have the fluid, plus or minus blood. This is dependent on, obviously fluid challenges depending on how much they're losing, how big or small, if they're a little old lady or a big guy, and what the hemoglobin is, and what the clotting is, and obviously regular OBS. Any clotting abnormalities which come up need to be corrected. So it's in the guidelines, but depending on the INR and things, either with vitamin K or with fresh frozen plasma as well. You wouldn't need to know that much detail, you just follow the guidelines with that and you're just suggesting. So obviously if they're really, really unwell, always catheterise because you need to monitor the fluid input and output. And obviously some of them could have a central line and go to HDU, ICU with extremely, extremely unwell. So something that you can prescribe is terlipressin, initially 2 milligrams over 5 minutes. So you could say that in an OSCI. I don't think you'd be expected to say any more than what's on this slide really, because it's all in line with guidelines really. So always say, with anything you prescribe, or give them an idea, but always say you do it in line with hospital guidelines all the time. So if the bleeding's still uncontrolled, there's things taking Blakemore tube and things, but that's not something we've really expected of us. It's just something to know about. Okay, so ROCL score, this could well come up in an MCQ and things. This is more just for the risk. So you can get this in any textbook or on the internet, just thought I'd put it up. So obviously it's under 3, you've got a better prognosis. Under 8, very high risk of mortality. So it's just good to be aware of this and to know about it, and you can mention it. Okay, so we're going to look at if someone presented with jaundice. I think the whole mechanism of jaundice should have been covered in the written lecture, so I'm not going to go over the mechanisms and everything. It's really complicated, and this is just more if someone presented with it or if you saw someone with it. So there's obviously different kinds, so you can split it up into sections. So think of anything pre-hepatic. So some causes might be malaria. So you'd know this from the history. They'd have, history of being in a malaria prevalent country, travel. They'd have all the other kind of symptoms with that. Hemolysis. And you'd look at hepatic causes. So paracetamol overdoses, viral hepatitis, again alcoholics, chronic liver disease. Gilbert's really, really rare, but something that could come up in a written exam. Again, you can get some things like this with pregnancy. Always ask about medications, about all that. So you just have to be really thorough. So also then now we've got cholestatic. So choledocholiasis, we're going to go through briefly, but I know this came up in our practice OSCI and it's in the syllabus, so it's something to know a bit about, and I'll go through it in a minute. Ascending cholangitis, pancreatic cancer, cholangiocarcinoma. So there's just a whole list of things. So just so you've got a few differentials, and I'm sure you'll do a bit more about them in specific lectures and when you're revising. You wouldn't be expected to explain any of these more difficult ones in OSCI. It's just to be aware of things for maybe some differentials. Okay, so some key questions you'll want to ask in jaundice. Again, I was going to not have this on the screen and get you to ask, but it's already up here. So you want to know if it's painful or painless. You want to know the alcohol history, definitely. You definitely want to know if they've got a fever, because you want to rule out things like malaria, anything infectious. You want to know if it's ever happened before, if it's new, how long it's been going on for. What's really important is to ask about the urine and the stool colour, so have they had dark urine and pale stools, for example. often pale stools difficult to flush away. That's quite a classic history. So also, is there any abdominal pain? Is there any itching? That's really, really common. Any really easy bruising, so any disorders with the clotting and things. Any excess bleeding, so any nosebleeds, bleeding gums, bruises really easily, anything like that. Weight loss, another red flag thing. Always ask about that no matter what history you're taking, really. Any joint pain and any tiredness. They're the key things to ask for if you're presented with someone with jaundice. So you also want to know about the past medical history. So again, have they had it before? Have they ever had any stones? Have they had any inflammatory bowel disease? Anything wrong with the liver at all in the past? Any autoimmune problems? And have they ever had a blood transfusion in the past? Always ask that one as well. So again, family history, liver disease. And again, like I said, really important for alcohol. I don't know why there's 7 there. That's just meant to be intravenous drug use. And again, like tattoos and piercings and things, you could have got an infection, hepatitis through that. Again, foreign travel to rule out things like malaria, and always ask about sexual activity as well. Okay, so some things you'd see, so with pre-hepatic, so you'd probably see a splenomegaly, for example, with malaria. You could probably be seeing pale conjunctiva and breathlessness due to anemia. So hepatic, if it's hepatic, you'd see the signs of normal chronic liver disease. So you'd see the hand signs, you'd see all the stuff you'd normally be looking for, and you'd probably be able to feel hepatomegaly. We're going to go over feeling in the exam in a second about what you'd feel for in a liver and everything. And also cholestatic, you'd have the tenderness, peritonism, and Charcot's triad is important to know. That could easily come up. You might get asked that in an offer, you might get asked that. So that would be fever, jaundice, and right quadrant pain. Some people might have a palpable gallbladder, and some people might be cachectic. The people you'll get in an offer will be well people just with, like we're going to go over, a kidney transplant, a large liver, a large spleen. We'll go over that though. Okay, so just lastly, I think in the history, nearly lastly in the history, choledocholithiasis. This didn't come into OSCI, but it came up in the practice one, and it could come up in the written. That's just a bit about it. You don't need to know that much. So risk factors, the 5 Fs. Are you all aware of the 5 Fs? Yeah, sure. So complications, obviously cholecystitis, cholangitis, pancreatitis, and more rare liver disease. So investigations, you'd always want to do obviously the blood, so LFTs, always do amylase and lipase. With anything abdo, any pain, anything like that, I'd always do amylase and lipase just to show that you're trying to rule out pancreatitis. Always clotting. And so you'd say those first, and you'd go on to the imaging and things. So you want to be in ultrasound and MRCP. Treatment, depending on what it was, obviously would be either a cholecystectomy or ERCP, resistant treatment. Okay, so just going to look at examination now. So like I said, I'm not going to go through how to do a full GI exam, because everyone knows that. I'm just going to go over things that have come up in the past. So I'm going to cover stoma, I've got some pictures and things, what you look at. Loads of people have them, so it could come up. Renal transplant, again, loads of people have them. I'm going to go over what you'd look at specifically. And also hernia, because that could easily come up, and it has in the past as well. So, to begin with, I'm just going to go over what you'd feel for, so any abnormalities in the abdomen. So, looking at the liver and looking at reasons for it being big. So, you do obviously your full GI examination, look at the hands, the face, everything like that. And if you do feel a large liver, you want to be seeing if it's irregular, if it's smooth, if it's thin, or if it's rounded. It's difficult to tell, but you want to be trying to measure it in like finger breadth or centimetres. And you can be doing that with percussion to try and kind of see how big it is. You want to be listening for bruits. And obviously when you're doing your GI exam, look for all the chronic liver stigmata that you all know about anyway. So some causes. Just for some differentials. Obviously, you're not going to have someone with some of these rare things, but just for some differentials. So obviously you've got primary hepatocellular carcinoma or metastases, CCF, cirrhosis, that, you could get something like that. Also hepatitis and infections such as Epstein-Barr virus. Non-alcoholic fatty liver disease, that can be quite common. And also someone with lymphoma. We had someone with lymphoma with a huge spleen and huge liver on our ward just through the week. You definitely have to feel that. Okay, so just look at spleen now. So to examine a spleen, obviously you all know what to do. You start from the bottom right and work your way up. So it arises from the left hypochondrium. You can't get above it. That's one way to know that it's a spleen. You might get asked how do you know it's a spleen. So you can't get above it. It moves downwards immediately on inspiration. It could have a powerful notch, but most of the time you're not going to feel a spleen unless it really is enlarged. And it will be dull to percussion. So some causes, obviously you can get massive splenomegaly, moderate and mild. So some of the massive causes, myelofibrosis, chronic myeloid leukemia, and malaria in some cases. In between moderate, so things like lymphoma, chronic lymphocytic leukemia, portal hypertension possibly, and hemolytic anemia. And some of these mild ones, there's quite a few, some rare. Just need to be aware of a couple in case you get asked. You might get asked what are some causes. You just need to know a couple really. And just lastly, so kidneys. So the enlarged kidneys would be palpable in the lumbar region. You all know where to ballot for a kidney. They should descend vertically on inspiration, and they should be ballottable. They're usually a resonant percussion, and you can sometimes get above it. So a polycystic kidney disease patient, you could easily get that. There's loads of people around with it, I suppose. This is just a bit about it. It could be an MCQ question, autosomal dominant. So it's just good to be aware of some of these things. And with a history, presents with bleeding, abdominal pain, hypertension. And do you know why they could get a subarachnoid hemorrhage with polycystic? Yeah, so quite common. Okay. Put in. It's just associated barrieaneurysms that can be associated with polycystic kidney disease. You probably never see it, but it can be associated with it. So, some reasons for the enlargement of the kidney. Obviously, like we said before, with the liver, so you've got carcinoma, hydronephrosis, obstruction. You could easily see that when you're in F1 on the ward. Could be a simple cyst, asymmetrical polycystic disease. It's normally both. So it's normally both kidneys, but you could be asymmetric if it was a polycystic one. Also, you could have you wouldn't have some with ascites in OSCI, because they wouldn't be the most stable people probably, but it could come up in a MCQ or something. The main causes, hypoalbuminemia. Cirrhosis is really probably the most common cause. More uncommon, protein malnutrition, malabsorption, and have you ever seen someone with nephrotic syndrome? You probably will see them. They've got a really swollen belly, so always rule that out. Children, I think it's more common in children. Portal hypertension with chronic liver disease. So again, it's always good to know about the drinking and about the past history. And also inflammation. Okay. So, first of all, we're going to look at a renal transplant patient. It's quite common in OSCIs. It's come up quite a few times in the past. If you want to, I don't know if you've all got the past OSCIs, but if you go into the Dr. Clark website, it's got a list of all the past OSCIs, so it's useful. And I assume someone else is going to put all the list up in another one of these OSCI presentations, what they did it last year. Because if you look back, there's always a pattern. It's always the same kind of things that come up. We didn't have a GI exam last year, so could well come up this year. And the three most common things are renal transplant, stoma, really easy, because there's loads of these patients about, or hernia. So you'd look at, obviously you'd start from the beginning, general inspection. Does anyone know why they have a sallow complexion? Does anyone know what a sallow complexion is? It's just kind of like a yellowy tinge to them. It's different from if they had kind of a liver disease and they were orange yellow. It's a different look. You'd have to go to a renal ward and look, but it's different. And it's caused by renal anemia. There'd also, because of the uremia and things, you'd also get excoriations, there'd be itching all the time. It could be short of breath and things from the anemia. Could be bruising, like clotting disorders and things. They're always on corticosteroids and immunosuppressives. So if you think about a cushion-eyed appearance, I suppose everyone knows what you'd look for there. What would you look for someone on steroids? Yeah, So they're often on a lot of immunosuppression, so they'd often have that kind of appearance. And also, I've seen before, and it's not that rare, but squamous cell carcinoma, like wart-like appearances. And this can appear due to the immunosuppression they're on. Also with the hands, I'm not quite sure whether they have the brown nail tips, but that's what it says in all the books, so look for brown nail tips, not 100% sure why. And look for the usual hand signs, but obviously specifically for anemia, so in the palmar creases and things. Always look at the arms, so they could trick you and obviously have someone with long sleeves on. Always ask to see their arms. Obviously there'd be a fistula there. When you see a fistula, don't just, say it's a fistula. You want to describe it and everything, so you want to say where it is. Is it brachiocephalic? I've got a picture coming up in a second of them both. Or is it radiocephalic? So once you've described where it is, palpate it. So don't press it or anything, just pop your fingers over it, and you should feel a continuous thrill. This would show that it was working. Also, you could auscultate it. You should hear like a continuing murmur. So yeah, these two suggest it's working. Then the face, just again look for everything you'd normally look for, but you could have periconjunctiva, periorbital edema, and in the mouth, I'm not sure whether they have halitosis, but it's quite common to have the gum hypertrophy due to the cyclosporin and thing that they're on post-transplant. So then you'd move on to the neck and chest. So again, look for the normal signs, but they could have vascular access scars from previous preoperative. They could also have parathyroidectomy scars, which can be associated with it. You look at the abdomen, and you'd see a classical, looks like a hockey stick scar called the Rutherford-Morrison scar. Okay, so that's what you'd be looking for, and it'd be going around into the back. So always get them in any abdo exam to go over onto their side, because you could miss loads of stuff on the back or on the side. They could possibly have a peritoneal dialysis catheter scar around their umbilicus. Often when kidneys are transplanted, they actually leave their native kidney in play. So that can be really easy to feel sometimes. So always feel for that. If you're wondering what it is, that they do leave them in place a lot of the time. It would normally be in the right iliac fossa, but occasionally it could be in the left, so don't rule it out from the left. Normally it's in the right, but it could be in the left. So always with anything you feel, always describe it. Consistency, size, just the usual things you describe any mass or anything that you'd feel. Also, you could ask the patient to lift the head off the bed, because if it's a muscular thing, that would show when they were tensing, whereas if it was in the abdomen, it wouldn't change on lifting the head off the bed, it would even maybe disappear. Again, ask the patient to cough to differentiate between kind of a hernia thing or whether it was just a few little things to ask the patient to do. So this is, in case anyone hasn't seen one, I'd suggest definitely go to a renal ward. That's what we did. We just went to like a cardiac ward, renal ward, listened to all the murmurs. We went to see all the fistulas, just so you know what to expect and what they look like. You're not going to miss it, it's quite an obvious thing. Okay, so always have, even if you know for a fact it's a kidney transplant, you always have to have some kind of differentials as well. So again, be systematic about it, like split it up into different areas, different systems. These are just a few things, obviously some rarer than others, but it's just good to have a few differentials to give, even if you're sure you know what it is. It's not going to be most of these things, but just so you know about them. Okay, so next we're going to look at hernia. So I'm not going to go through all this. This is from a book. The most important bit is the middle bit. So, because this is where you're going to examine to find out if it's indirect or if it's a direct hernia. So it's the deep inguinal ring. So it's halfway between the anterior superior iliac spine and the pubic tubercle. Yeah, and this is what aids in determining what kind of hernia it is. We'll go through that. Okay, so with a hernia, obviously you've done your full GI exam, like with anything, and then you come to expose the person when you see this hernia. So always ask about pain, and you do that with any GI exam. Always ask about pain when you're doing it, and always make sure when you're examining them, you're on a level with their stomach, and you're always looking at their face to see if they're in pain. So you do that with everything. So you need to examine them lying down and standing. So first of all, like anything, you'd inspect them, you'd describe the size and shape, all the usual things, where it extends to. Are there any scars? Could it be an incisional hernia from an operation? Are there any groin swellings on one side or both sides? I doubt we'll give you kind of a groin one in an exam because it would involve the patient having to expose themselves. But you'd obviously say that that's what you would do. You'd want full exposure, from nipples to knees, they say, but you wouldn't really do that in an actual OSCE. I don't think any patient would like to have that done. But just say you'd do that. And ask the patient to cough. So next you would feel the hernia. So you're feeling the temperature, you want to see if you want to look if it's hot, if it's incarcerated or anything, if there's any signs of inflammation. You want to feel the consistency, the size, is it fluctuant? This is with any mass really. Can you get above it? Get them to cough again when you're actually feeling it. Is there a palpable cough impulse? And then you want to know if the hernia is reducible. Ask the patient this beforehand. Ask if they can get rid of the hernia themselves. And if they can, get them to do it first. If not, obviously you try and push it in and ask the patient to cough again. So this is where you need to know where the deep inguinal ring is. So halfway, reduce it, pop your fingers over the deep inguinal ring. If it can be controlled, this is an indirect inguinal hernia. And if the hernia fails to be controlled, this is a direct inguinal hernia. So, also in real life you wouldn't really auscultate it and things, but in an exam, just cover everything. So you'd auscultate for bowel sounds. Obviously if it was a mentum and fat, it would be dull, and there'd be no bowel sounds. A resonant hernia is likely to contain bowel leaks. So the only true way to distinguish, really, in reality, is intraoperatively. Okay, so again, a few things of differential diagnoses. Even if you know it's a hernia, it's always good to have a few things just to list. Some of them are really random things, but it's always good just to know at least like 2 or 3 differentials for it, because you could well get asked that. Okay, so just a couple more things to go through. So we're just going to go through stomas quickly. Loads of people with them, and it's such an easy thing to have in an OSCE. So again, you do your normal GI exam. The actual marks for these things wouldn't even be that much. They want to know that you can do a full GI exam and just recognise any abnormality. So most of your marks come from the actual full exam. So you don't actually realistically spend that much time. You just have a look and have a feel and things like this. So sight often can be in the left or the right. Do you know what's more likely, what kind of stoma is more likely to be in the right and what's more likely to be in the left? Yeah. It's not, colostomies can be in the right, but it's more common to be in the left. But yeah, ileostomy is in the right. And I've got some pictures of a colostomy and ileostomy coming up in a second, in case people haven't seen them. So, you've done your full GI exam and you've found this stoma. What I'm about to go through actually only takes about 20 seconds, but we'll just go through a few bits. First of all, you want to be looking at the bag. Is it solid or liquid? Do you know which one's which? What would you expect with an ileostomy? Yeah, and with a colostomy? So like, yeah, semi-formed, brown kind of stool, whereas ileostomy more kind of, yeah, watery, greeny colour sometimes. So you want to know what's in it, and that gives you, obviously tells you kind of what it is if you were unsure in the first place. You want to know if there's any blood in the bag, any mucus. Blood's not normal, mucus can be, so blood is probably quite worrying if you saw that. You want to look at the surface. This is obviously as well going to tell you what it is as well. Do you know what an ileostomy looks like? What's the difference between an ileostomy and colostomy? Just the actual outside. Yeah. Do you know why it's protruding? Yeah. It's just a corrosive content that's going to come out with it. It just protects the skin so they have a spout with them. So after you've described it and you kind of have an idea what it is, you want to be looking around the actual stoma. So is the skin healthy? Is it really red and inflamed, infected? It's difficult to tell this next bit, but try and look to see if you can see kind of a single lumen or a double one. Obviously a single would be an end colostomy, double would be a loop one. It's difficult to see, you probably wouldn't see it, but just try and have a look. And also, are there any surrounding scars, obviously from operation? And ask the patient to cough again, just to check if there's any hernias or anything. So this is what they look like. So it's quite different. It's clearly a spout there on the left one. That's an ileostomy. And the one on your right, obviously, is more flush with the skin. So that's classic of a colostomy. Okay, so always think about the complications of stomas as well. Fluid loss, odour, alteration of the skin due to the content, leakage, loads of things. And always think about, obviously, for the patient, the sexual and psychological problems and stuff as well. Terminal ileum as well is quite important to remember that, you know, the failure to absorb all the bile salts from the B12, that can lead to a few problems in itself, so always remember that. Okay, so once you've seen this person, always summarise at the end. So for example, this patient has a stoma with one visible lumen in the left lower quadrant with the mucosa line flush with the surface of the skin. So that can be seen to contain semi-formed stool as well as mucus. These findings are consistent with an end colostomy. The surrounding area of the skin appears healthy and there is no evidence of a parastomal hernia. So just something like that at the end. These are just a few things, a few kind of reasons for colostomies and ileostomies, where they'd be, what to look for, just to kind of summarise it there. You can note them down, you know, another time, because this will be up on the website anyway. Okay, so just to finish off, just some slides. The slideshow is, there's no massive surprises. It's stuff that kind of comes up every year. So what investigation is this? What's being done? Anyone know? Yeah. So what would you say, just hazard a guess at the diagnosis? What histological, that gives it a clue as a diagnosis, what histological changes would you expect? Just give the answer. Okay, so yes, OGD, you were right. Barrett's esophagus. Do you know what predisposes to Barrett's esophagus? Yeah. And you'd see squamous to columnar change. Okay. The next one, what is this? What causes it? And what procedure may be used to treat? Anyone have it a guess? Yep. Okay, so ascites. Oh, that's actually the next slide. So portal hypertension can cause this. And you'd have a paracentesis, but obviously with that, there's a risk of spontaneous bacterial peritonitis. So you've always got to think about that. Yeah. Okay. So this is a really obvious one. You've probably seen it before. Quite a classic one. It could easily come up in a slideshow. So what investigation is this? And what is this? What is it called? And what do you get this in? No. Yeah. And what do you get the apple core sign in? Okay, so rectal carcinoma. So it's a bariomenoma, and it's a classic apple core sign. As you can see, it looks like an apple core. And you get it in rectal carcinoma. Okay, we had this in our slide. So there is some weird ones in the slideshow, but most of them are things that you've seen. You'll have a slideshow lecture, and it will go through loads of stuff, and people always have practice ones that you get emailed around. Just go through as many pictures as you can. But this came up. This is a really straightforward one. What can you see here? And what's it called? Yeah, and can you name two causes of it? Yep. So pneumoperitoneum, bowel perforation. You can also get it post-laparoscopy. Okay, so I think this is the last one. So what can you see? It's the same kind of thing in both. What can you see? Yeah, what are some causes? And do you know how to tell the difference? You know, on the large bowel you get the haustra, and on the small you get the valvulae conniventes and stuff. Okay, so yeah. So it's large and bowel obstruction. So loads of causes. So just know a couple of them, so you can reel a couple off. So constipation, hernias, adhesions, tumours, Crohn's disease, gallstone ileus, volvulus, and treatment, F1, dripping up. That's what, I think we had that in our slideshow last year as well. So it is most of the time quite alright stuff. Yes, and that's it for the slides. Any questions? Hopefully not complicated ones.
Two things to that. If you were to get how would you tell them? So if it was pre-patch, ALT is generally
Yeah, don't run out of time. I ran out in time in one of them. I was focusing so hard on trying to murmur. It was a cardiac exam and someone had a big pneumonectomy scar. I think what had happened in hours is the cardiac person hadn't turned up the afternoon and they'd sat someone else in. So I spent so long trying to listen for a murmur that I didn't even have time to do the ECG, interpret the ECG or do anything like that. So yeah, don't waste all your time trying to listen for something, or say exactly what you hear, say exactly what you see, and just make sure you've got time to do the basic then, because there are more points really. As long as you've done your main examination, like you said, diagnosis is 1 or 2 points. So just
On that point, I did the same thing in my childhood. I was too busy worrying about the learner, couldn't decide whether it was AR or MR. Knew it was one, knew it was one of them, so I couldn't decide whether it was microreadable or you don't need to know the diagnosis, or something you can actually do in AR. I then got given the issue in AR, and if you microreadable, you're more likely to go AR and dilatation correctly. So I think I gambled over my it's all easy to realise it was AR, and then say actually, I think this is all I was behind. So it's all right to change your mind, as long as you then giving you some action. There are no ways to go to that stage. So don't get worried about something. Any questions?
I'm just wondering, don't you get a diagnosis and do wrong,
Yeah.
and then you go off on a manual plan?
They prompt you, yeah. So if you were to give the wrong diagnosis and you were completely off, they would say, well, what we can do, and they would guide you back towards the diagnosis. The penny might not drop, so you just forget about it, move on, there's other stations to go. That's what you would. But yeah, they do try to happen. Obviously it depends on a lot of them have
yeah, most of them are nice.
So when I was doing the cardiac examination, I said it was not sure. I then saw the ECG when because the patients are all normal patients from the hospitals, and they all want to do it. So it'd be really nice to them, right, which of these cells don't promote people looking
Yeah, just be really nice. They score you. As long as you're really nice to them, they'll give you really, really good marks. All the patients will. And we didn't really cover explanation stations that much in here, but it's just the usual with any explanation. Even if you're not really 100% sure of something, just do the usual. Ask what they already know. Ask what the concerns, the ideas are, what they expect out of it. Ask what they understand from it. Just the usual things. So even if you don't know much about it, you can always get loads of marks because you just being nice to them, chatting to them, just the usual things. So it's honestly, fourth year is so much worse. So if you do fourth year, fifth year, fine. So just do some on call. That's the one thing I didn't really do many of. I should have done. Do some on call because that's what they want it to be. It's an on call. That's what they aim it to be. So I really would advise you to do a few on calls, which I didn't really do. So yeah.
The mock OSCE is still on 29th of March. We're finalising the final details at the moment. Going out emails and probably Facebook when we confirm the fully, but we definitely got to the report. We're going to run, I think, 20 stations, so it's going to be 2 circuits circulating, and hopefully we can get that equal through time, so probably 6 lots on the day. I don't know if we've got through your first lot of feedback, what the
bit nicer, isn't it? And you'll have the other mock OSCEs that Coldell do and Bradford do. Do as many as you can. They're really, really good.
Anything else you want to raise or anything you think could be better apart from the lectures? Brilliant, thank you very much. And yeah, if I could have your feedback for all that, that'd be brilliant.
Cheers, thank you very much.
Thank you.
Hello, hello.
Thanks very much. Yeah, that kind of
Day we've got, I'm afraid. And we nearly
just
did.
loads of x-rays,
Um,
ECG, classic things. I could have kicked myself,
I mean,
but
if
in
we get
last
a
year,
place, we can maybe
it was
do it. Let's get one that's going to
15
run throughout.
SMQ323 thing.
If your name
It just
gets
showed,
on the list, I can
it
make
just
sure that
showed
you
these
get on
1 and 3.
my
Obviously that's what it was, and I was like, is it two-way conversion? Like, so look at the classic ECG. It's gonna be
If you're on the list,
it's
we
gonna
can
be
make sure you're
something
on
classic. It's not gonna be something completely
How you
random you
doing,
don't
you
know. It's
Obviously,
gonna
there,
be
obviously,
that you'll have like again a
After
new
the
infection.
gastroenterology, it's
You'll have
carnage.
investigations. ECG. You'll have.
Good,
We
no
have
problem. See you in tomorrow.
that's on all the
See you then.
practice slides. There's nothing really that new. It's just
Not
it
yet,
is
no,
scary
we're just
because
about to
literally
start
got blank
and
paper
go
in
out
front of you.
on-
So it is in that way worse than thought.
I'm hoping to be
I think it's quite hard.
out there.
I mean, it sounds really good if you
Because
can.
yours are all...
But yeah, you panicking all the time, so you normally don't. But always give a little. Don't say negative stuff. Just say the positive. Don't say they didn't have this, didn't have that. Just say what you
I
positively
don't know,
found.
I like cardiology.
Yeah.
I like cardiology.
Or there's no peripheral stigma to do.
Cardiac surgery is just...
Everything. Don't say there's no difference. Just say what you see. And honestly, in exam, just don't
There's an
try
ST
and
one
look into something
run-through
because
program,
you will run out
which
of 8
applies
minutes.
to the
Do
F2.
the exam. Let's look at investigations, talk about management, and to present to summarise. But always ask you
It's either that or I'm still, I can't, don't know. Medical or surgery, not GP.
Again, explanation, it's like this, from one day, it's all explanations, and then the next day it's all exams. That's what was last year.
Well,
All
that would be
5
one.
days, more skills. Next day, skills and that. We had ABG.
Do you remember the
Gonna back up again. Can you leave it into ABG?
I'm sure. Cool, alright, I'll see you later. Take care.
So expensive to get all this stuff. So can you leave it?
Yeah.
So honestly, like, it's not as bad as what
Yeah.
you're not gonna get something that you have no idea about, and you might get the odd
MR.
weird explanation.
So yeah, so
But just
why?
really nice.
So
to-
when
and
so you
just
listen to that, your
what you
AS
know.
should sound
Like prepare what you're
loudest
gonna say
and
if you
the
don't
left
have
sternum
to.
line.
Like prepare a few questions you
Should
can
also
say if
rate
you
it
don't obviously, and then at least
So I did
you
all
don't
that.
obviously,
I
you
was
can kind of think, all right, do it
yeah,
like
yeah. And you're not thinking straight.
because
Yeah.
you do
So and then they'll allow us to. So you listen to it as a murmur. And you're like, right, okay, what can I
it's
do?
fine. You can get it right.
Essentially, she had a big scar, so I knew she had either a cabbage or a murmur. I heard of the murmur, so it's not she's got a bad aortic stenosis. You wouldn't get the change in like AF because you're so if you think the atrium pumps normally, it goes into your ventricle and your ventricle fires up. That valve doesn't open quite as well as it should spin. So the change you get in the heart there is that the heart gets large. So if you were to see anything on the ECG, it would be
You don't know.
like LBH, hypertrophy, large QRS.
So what risk? No, what?
So that's what you see with aortic stenosis generally. With mitral regurg, what happens is the ventricles contract, and because the valve in the mitral valve between the two doesn't close properly, you get blood pushing back into the left atrium. You've also got blood coming in from the pulmonary veins, so instead, because of the pressure of the ventricles, that mitral valve expands, and when that mitral valve, that left atrium expands, and because the left atrium expands, the electrical signaling causes, comes across from its SA node, it doesn't work quite as well. And so if you have mitral regurg, you will at some point generate that. And generally, by the time that you have a mitral valve replacement, it's the MR significantly reduced to warrant an operation because it's a serial question. You have so that's was the little alarm bell that I noticed. Even if you didn't notice that, yeah. No, but that's what fifth year is more about testing. You get through the cardiac exam, you'll do well. You'll still pass. You'll still do everything you need to do. In fact, I just need to save this.